We're going to have a full house, which I'm really happy about. Welcome and good afternoon. My name is Tony Danuzzo. I'm with the Seeley Center on Aging and the program coordinator and director. I think we have some mutes on. Could we mute Kelly, please?
Hello.
Hi. We're going to get started. Okay, great. Thank you. And I'm program coordinator, director for the East Texas Geriatric Education Center. And this is a lecture series in basic geriatrics and gerontology that we're having on a monthly basis. This is the second in the series, Introduction to Interdisciplinary Teamwork in Geriatrics. And we also have, as part of the East Texas Geriatric Education Center partnership with the East Texas Area Health Education Centers, or AHEC. And just out of curiosity, we have recruitment going on for this program that we're offering for healthcare professionals to obtain as high as 160 hours of credit towards a certificate we'll be giving out as a Scholar of Aging if it's all completed, as well as other parts of the program. And with our recruitment, we've had a lot of response, and we have close to 100 people that have basically expressed some interest in participating in this program already. It targets the East Texas area as well as UTMB. So out of curiosity, I'm just kind of wondering in this room, with a raise of hands, how many are actually signed up and have registered for our program, for the Scholar of Aging program? Okay, good. We got a couple. Great. How many people are here for CE credits? Great. About half, a quarter, about a third. Good. How many are here for the food? Okay, and everybody else is here to learn everything there is to know about interdisciplinary teamwork in geriatrics. All right, okay, that's good to know. So now we know why we're here. Very good. We have an agenda, and hopefully everybody got a handout. Hopefully we didn't run out, but there will be a break at about 1:15. We're going to try to keep to this time. It might vary quite a bit, but this is going to be going for 3 hours and until 3 o'clock, and we have a break at about 1:15. So if everybody needs to take a break then, that'll be the time to do it. This, as I said, is the second in a series of lectures given on the second Friday each month from 12 to 3 p.m. And these are the topics for the next 10. August, we're going to be having a lecture on geriatric assessment. We have several people lined up already for that presentation. That it's going to be covering cognitive assessment, physical, functional assessments, as well as basically what we do for assessments in our clinics. And this is in your handout. If you ever need any information about this, just let me know. One big highlight for this program is that we're broadcasting to several sites throughout East Texas, including Lamar University in Beaumont. And I'd like to welcome Dr. Eileen Curl, who's the chair of nursing at Lamar, as well as Kelly Buchanan, who is Dr. Kelly Buchanan is our AHEC coordinator for the coastal AHEC region. And we have Stephen F. Austin State University. Oops. Let me put this on there so people know what I'm looking at. There we go. Stephen F. Austin State University in Nacogdoches, and Dr. Peter Simby is our contact there. And we also have Sylvia Baker, who is our AHEC contact. And for the Piney Woods AHEC region. Okay, and also then Sam Houston State University in Huntsville. And we have Dr. Alessandro Bonanno is our contact. He's a professor and chair of the Department of Sociology. And finally, we also have the University of Texas Health Center at Tyler. Linda Smith is our AHEC coordinator for the Lake Country AHEC region. See, we have several credits that we're offering for continuing education, including continuing medical education, the CME credits for MDs, DOs, nurse practitioners, and physician assistants. This has been accredited for 2.75 hours, and this is the procedure. It's in your handout if you need, in terms of what you need to do to obtain these credit hours. We are offering partial credits if you cannot stay the entire 3 hours and you can only stay for half. Half of the credits will be awarded to you for CME. Okay? Any questions for the CME part? Okay, the evaluation form is very important to hand in, and obviously signing in at the attendance sheet. Okay. This is the contact information for the Office of Continuing Education offering our CME credits. You can also take a look at our website on the East Texas Geriatric Education Center to get some more information about this, if you'd like. We're also offering C&E credits for nurses, and right now we're accredited for 3.2 contact hours, and this is the procedure for obtaining those hours. We have the sign-in sheets, and we have evaluation forms specifically for the C&E session. Okay? The important thing to remember for C&E is that if you want to obtain the C&E credits, you need to be here for the entire 3-hour session. There's no partial credit for the C&E as of now. We are applying credit for LVNs. Unfortunately, we haven't received final approval for C&E for LVNs, but it's getting closer. They assure me that it's worth applying for the credits, send in the evaluation forms, and do the sign-in sheets, and as well as the credit request form. But tentatively, they will be able to give you a certificate of attendance for the LVNs. Okay? I wish I could promise that, but we're working on it. Okay? Any questions regarding the CNE? Okay. And last but not least, we have CEUs for social workers. This is for the first time we've been able to offer this. We have 0.3 CEUs awarded for social workers for this 3-hour session, and they must be present for the 3-hour session. There's a separate evaluation form for the social work CEU, and as well as needing to sign a separate sign-in sheet for the social workers. If you have any questions about that, please let me know. Okay. All forms could be handed in either to me or to Beth Schilling to obtain any CE credits for today. Okay. And here we go. We have 2 speakers today, and I really would like to thank these the 2 speakers for being so easy and to work with and enthusiastic about what they are presenting today. We have Cheryl Lehman. Many of you know. Cheryl received her diploma in nursing from Decatur Memorial Hospital of Nursing in Illinois in 1978, and her BSN from Maryland University in St. Louis in 1990. She graduated from nursing, a clinical nurse specialist track at UTMB School of Nursing in '94. She specializes in rehabilitation, skin, and wound care, and has several publications in critical care nursing. She has been with Geriatric Services on the ACE unit at UTMB since 2003, and is currently enrolled in the Department of Preventive Medicine and Community Health PhD program, the Rehabilitation Science track at UTMB. And also presenting today after Cheryl is Diana Reed. Diana Reed attended Vanderbilt University and received her BA degree and a Master's Social Work degree from George Warren Brown School of Social Work in Washington University in St. Louis. She's practiced over 30 years in medical social work, specializing in geriatrics and in rehabilitation. She is an LCSW, a Licensed Certified Social Work? Got it. All right. Okay. Approved supervisor granted by the Texas Board of Social Work Examiners, and is a master trainer in the Chronic Disease Self-Management Program. She's currently the social work supervisor in geriatric services at UTMB and is the discipline coordinator for social work for the East Texas Geriatric Education Center. And welcome. Finally, It is required for me to state that today's speakers, Cheryl Lehman and Diana Reed, have no commercial affiliations to disclose. Okay. So, right on time at 12:15, I'd like to get started at an introduction into interdisciplinary teamwork in geriatrics. Cheryl. Oh, yeah.
Okay. I think I did that right. Hi, and welcome. And the first thing I want to ask, Diana and I, when we started doing this talk, putting this together, we weren't quite sure who our audience would be, and I don't recognize everybody's face. So just to get an idea, and those of you that are out at the distant sites, if you would help us out here too, I think we can see you well enough. How many of you here are nurses? Okay, quite a few. Social workers? Okay. Pharmacists? I know we've got Crochet and her student. Okay, physicians? All right. Therapists? No therapists. Oh, we can talk about them behind their back. Okay, that's good. Who did I miss as far as disciplines? Nutrition? Okay. Okay, good. Well, we'll be nice then. Thank you. Thanks for speaking up. How about faculty? How many people are faculty? Anybody? Okay. And students? How many of you consider yourself students? All righty. Practitioners? How many of you actually participate in hands-on patient care? Okay. All right. So we've got a good mix of people here. There's a lot of information we're going to give you today. There's going to be some audience participation, and here are the objectives. Of course, we want to compare the types of teams that are out there, the advantages of using an interdisciplinary team in geriatrics, and there's some research on that I'll give you. Benefits and challenges unique to the team environment, stages of team development, but the most important objective is the last one. We'd like to help you learn things that you can apply in your own setting and help you delineate strategies to achieve productive teamwork in your own environment. So, of course, you always have to start with definitions. And I saw one definition last night. I was going through a catalog when I was at the vet with the dog. And this is T-shirts. And it just says a team effort is a lot of people doing what I say. You know, that's my kind of team. But I think there's other kind of teams out there that we're really supposed to talk about. Okay, so a team basically is two or more people working toward a common goal. And we all grew up with the baseball teams and the basketball teams, and their, of course, goal is winning. Ice hockey I learned to love in St. Louis, and I think the goal in ice hockey is winning plus blood. I really think that's it. And your factory teams. The one that came to mind, my father worked in the automotive profession, and the Japanese were the early ones that came up with the sort of factory teams where the goal was a really good product at the end of the line. There's another just generic definition of a team, and people who are committed to a common purpose with performance goals and an approach for which they hold themselves mutually accountable. So those are your generic kind of teams. As far as healthcare teams, I don't know if any of you nurses here are old nurses. I know Jean Ann is. But, Amelia. But when I started nursing, and I was a baby nurse in nursing school, we were not introduced to any other professions. I started out at a 500-bed hospital, a non-for-profit hospital in central Illinois, in a town of about 100,000. At Decatur Memorial Hospital, I didn't know of any other disciplines other than physicians and nurses. And the teamwork consisted of the physician telling the nurse what to do and telling the patient how they would react. That was it. And the nurse was allowed to participate in the teamwork by holding the physician's charts for them as they went from room to room. That's about what it was. Other disciplines, I have a vague memory of a tour of the hospital, and whoever was giving us the tour pointing out the window or the mirror with speech therapy did some of their work with patients. I can't say I ever saw a speech therapist, but we saw the mirror, so at least maybe there was somebody around. Then I moved to the Catholic hospital across town, and they actually had a pastoral care team. So we had somebody to call, to deal with deaths and other situations like that. They had social workers. But that was about it. The pharmacists at both hospitals were down in the basement someplace. They supplied the pills. And I guess at St. Mary's we had a physical therapist, but she operated in isolation, and she operated on physician order. So she'd come and see a patient and disappear, and there was no communication. Well, interdisciplinary teams, I guess, started to take hold in the 80s. It really started to become a force. Rehabilitation had interdisciplinary teams for a long time, and they were probably the first to recognize the value. And now interdisciplinary teams are becoming a way of life. JCO, if you read the JCO regs, interdisciplinary team is all the way through it. Your documentation needs to be an interdisciplinary focus. Your plan of care, your assessment, the whole works. They want to see proof in that record of an interdisciplinary focus. And so an interdisciplinary team is simple enough. Team of caregivers who work together to develop and implement a plan of care. The membership's going to vary. This is all common sense stuff that I'm going to start with, depending on the services required. Your core team is going to be the physicians and nurses and pharmacists, social worker, probably dietary. Those are probably the core people of an acute care interdisciplinary team. But there are also, I like the term spiritual advisors in this one. I wasn't sure quite what they were talking about, but I guess it fits all populations if you say spiritual advisors, even the people in California. Personal support workers, volunteers. Okay, so just some basic terminology so we are sure that we've reviewed this. I'm going to start backwards on this slide with transdisciplinary. Transdisciplinary is a term that you don't hear much in healthcare. I think there have been some efforts to make it happen, some sort of brainy people that have thought this would be a good idea, some accounting people in facilities that thought, oh my God, if we could have everybody do everybody else's job, that would be a perfect world and it would be cheaper. And that's what transdisciplinary is. Everybody learns everybody else's job and you function just as a single entity. That's probably a little farther than most healthcare facilities will get. But multi, the basic definition is BENI, and multidisciplinary, a combination of disciplines and methods. Inter, the two key words for interdisciplinary are mutual and together, and interdisciplinary involving two or more fields of study. Multidisciplinary is a collaborative process, but the different disciplines treat the patients independently. They assess them independently, they treat them independently, and then they share the information with each other. Interdisciplinary is different. There is an active pooling of knowledge. They're interdependent in their work. It is a whole different level than multidisciplinary. Around here at this institution, they tend to talk how things in the past have been in silos and we're moving away from that. We're moving towards a more interdisciplinary focus is the goal. So just to sum it up, multidisciplinary, they tend to work in parallel, the different disciplines. There's no overall plan of care. There's no overall priority. And how do they learn to work together? They learn to work together on the job. It's hierarchical, and traditionally the leader is assumed to be the physician. And the patient's not considered a team member. The patient is considered to be the patient and will be informed about the plan of care after it's made, probably by the leader. Interdisciplinary, integrated, agreed upon goals. One thing that comes in with interdisciplinary, and you'll hear this over and over during this talk, is regular team meetings. And at least in my experience, you can say you have an interdisciplinary team and you talk, but unless you actually sit down and have something regular where the purpose is to talk about the patient and help develop a plan of care, you're not going to get the true interdisciplinary outcomes that are possible. The leader in an interdisciplinary team changes depending on the patient's need. So if the need is acute care medical, then the physician's going to lead it, but then all of a sudden we've taken care of the congestive heart failure and our problem is money for medications and placement. So the social worker's going to take it from there, and then maybe, they can't do their ADLs well and they're not safe at home, so therapy steps in. So interdisciplinary, your leader's going to change. And the patient is a team member and is a focus of the team. Okay. Again, membership depends on the setting and the needs of the patient. It can be different from patient to patient. Core members for an acute care patient might look something like that with the physician, the nurse practitioner, social worker, and the pharmacist and patient. Physical therapists at this institution, physical therapists and occupational therapists are core members. Speech therapists, many times you don't need a speech therapist there for, you won't keep them busy. You're not, the majority of your patients will not have speech needs, swallowing or communicating. So there might be a consult service. Dietitian you'll probably have as a member of a core team. And I'm talking inpatient. A lot of these will cross over outpatient as well. And then just some other team members that might be considered as part of the team, audiologist, psychologist, chaplain, and your other consultants. So why have interdisciplinary teams anyway, particularly in geriatrics? Why worry about it? Why is JACO worrying about it? Who cares? Well, there's starting to be studies, since there's been an increased focus on, oh God, you got to have an interdisciplinary team, you know, to be a real place. You got to have an interdisciplinary team. There have been starting to be some studies reported in the literature, and this group is from Brazil, and they looked at the cost-benefit relationship of a type of approach to hip fractures and other fractures in older people. And they looked at a population, I don't know how you pronounce that, Sao Paulo? Okay, in that place. In that place, the age of the population that was 60 and above doubled between 1981 and 2001 from 7.5 million, nearly doubled, to 13 million. The public health system cares for 70% of the population, and they had nearly 47,000 hip fractures in the area, I believe, in 2001. This group did an interdisciplinary process that's sort of basic. The patient on entry into the system through the ER or ambulatory care was seen by a geriatrician as well as the orthopedic MD, the orthopedic surgeon. And once they were admitted, they were seen daily by those two physicians. From the beginning, therapy was involved. There was caregiver training. There was home visit follow-up after they fixed the hip and discharged. And OR was scheduled as early as possible in the hospital stay. Look at how they decreased the mortality. The average rate in the city was 5% mortality for this post-hip fracture. And just through the interdisciplinary team, they got theirs down to 1.4% within 3 years. And so when you think about, oh my God, just having an interdisciplinary team, you can decrease mortality. That's pretty powerful. It's pretty powerful stuff. This group looked at, it was a randomized clinical trial that lasted 18 months, and they looked at an ambulatory clinic in a community hospital. Their population was, this was the United States, their population was 70 and older. They had Medicare, they were community dwelling, and they were considered high risk for hospitalization. The team that was involved was a social worker, geriatric nurse practitioner, geriatrician, and a nurse. And that group was available for 24 a day on-call service 7 days a week. There was free transportation to the clinic, and there was telephone follow-up after the visits. They looked at a bunch of different outcomes. They did not find a change in mortality, in the use of the clinic health services, or in their Medicare payments, but they did find a reduction in functional loss in the treated population. So the people lost less function when there was an interdisciplinary team looking at them. Fewer increases in health-related restrictions in ADL, less depression, and less use of home health services in the group through the use of the social worker, geriatric nurse practitioner, and geriatrician. So that's pretty remarkable too. And the cost for implementing this per person for the 18 months was $1,350. So if you saved some function for $1,350, again, that's probably a good indication to have an interdisciplinary team look at the outpatients. This group was in Norway, and they looked at the difference between a geriatric inpatient unit and a regular general medicine ward. It was prospective, randomized. Patients were 75 and older, admitted to the Department of Internal Medicine, and they, on admission, were randomized to the geriatric specialty unit or the interdisciplinary team geriatric unit or the general medicine ward. The team that saw the patient in the hospital were physicians, nurses, OT/PT, social work was available on consult, and they had a dentist available on consult, which I thought was interesting. I hadn't heard of that before, but that was good. The patients that were assigned to that were included in the study had at least one characteristic that made them frail by the definition that the group used. And it could have been dementia, could have been urinary incontinence, could have been dizziness, falls. Anyway, they had a list of things that made the patient frail. If they met one of those criteria, they were included. Intervention was interdisciplinary assessment, early prevention, or prevention of complications, early mobility and rehab, and comprehensive discharge planning. There was no follow-up after discharge from the hospital. This was all inpatient stuff. Look at the decreases in mortality again. It was quite remarkable at 3 months, 12% mortality versus 27%. And that hung on out to a year, 28 versus 34%. So makes you not want to stay on a general ward in Norway, but, you know, it's pretty remarkable results again. And I think I got one more from Ohio. This group looked at they had a stroke unit, and they converted it to the ACE unit model. And they brought in a geriatrician who is experienced with the ACE unit model, acute care for elders model of care. And he became the unit coordinator for the unit. He was the leader. But they had the stroke physicians, the neurologists. The team consisted of nurses, clinical nurse specialists, social work, PT, OT, speech, dietary, pharmacy, and physicians. Average age was 72, pretty much split male and female, pretty much a non-minority population. But they were able to decrease length of stay. The discharge location was more apt to be home. And readmission rates had gone down through the use of an active interdisciplinary team. So interdisciplinary teams work. The literature is starting to be published on this, and it's very interesting. Did you have a question?
I was going to say, I'm with the CEUs team,
Uh-huh.
and Jacob with the rest of the team. But before I came, they had done a study in-house for readmissions because it's such an expensive admission. And between the interdisciplinary team and the start of a clinic specializing in that, we decreased 41% of readmissions.
That's amazing, yeah.
Of course, you're going to see more admitted because people are surviving heart attacks now where they didn't. So just call us.
Excellent. Okay, so one of the questions, thank you for that. One of the questions that could come up is, so in geriatrics, why worry about this population in particular? Well, I think the people that work in geriatrics a lot, this is basic knowledge, but they have very complex needs. They're walking that tightrope of health and not health, and it doesn't take much to put them over the edge into not health. Multiple chronic illnesses. I mean, how many people that are old do not have a chronic illness or two or three, and multiple treatments, multiple medications? Unexpected acute illnesses are really tough on this population. And there are normal changes, too, that also affect the population as a whole. Changes in functional status, changes in the social structure, social support system. That's very important in this population. And changes in finances. Can't afford the food, can't afford the transportation, and can't afford the meds. I mean, that's the meds, yes, pharmacist personally. Thank you, Crochet. I freely stole some things from Dr. Goodwin's talk last week, and this is one of them. Traditional care of the geriatric population has been the medical model. You have the geriatric patient who's going through life, has an illness, okay? Sees a physician, he does something, and the expectation is they'll get well. Okay, that probably works for the younger age groups just fine. Periodic visits for an acute illness, you fix it. But for the geriatric population, it's different. Because, don't you like these slide down boxes? I mean, you know, this is my new skill. And the arrows were very difficult, but I overcame that. Okay, geriatric model. You have all these factors in this population that we just talked about, the social factors, the multiple illnesses, and they're all different kinds of factors and factors of differing strengths. And at the very end of it, you have a geriatric patient with a problem. So, for instance, we could have a vision problem. Cataracts, not unusual in the population. They have problems with vision before the surgery. They have problems with vision after the surgery. It's just not a fun thing in the first few months after the cataract surgery. There's a lot of things that can happen. Let's say that this person also has hypertension, but she has hypotension now. She's been being treated for hyper. Now we've gone the other direction and we're hypo. Okay? So you have some problems there. Throw rugs. The woman has throw rugs all over her house. She has stacks of newspapers and boxes and stuff. Okay? So she's got an untidy house. Ooh, that's not a medical thing, but it is a factor. And then medication compliance, which is how we got to our hypotensive stage. Okay? And all of a sudden, we have a geriatric patient who is falling. Okay? If you just look at the fact that she comes into the clinic or into the hospital and she's falling, and you take care of her bruises and her broken bones and you don't do anything else, you just miss the point of care for this patient. So, I got 2 out of that one. Vision. If money for glasses is the issue, well, this is an indication for maybe social work to help out. Find a funding source. Help out here. And you take care of that one factor, you've taken care of a lot of things. The hypotension could be due to medications, dehydration. Physician and pharmacist would sure be useful here. But how about if it's because she only turns her air conditioner on at supper time so she can eat comfortably, but she has the air conditioner off the rest of the time and it's August in Galveston? I mean, she's saving a few cents, but she just dried herself out. Social work would probably be helpful there too, and that's something you might not often think about if a patient's admitted with dehydration. Call in social work. But it could be very apt. Medication compliance. Medication compliance can be from a bunch of things. Cognition. OT and social work would sure be, speech therapy would sure be helpful there to help to try to figure that out. Psych consult, a lot of different things there. Medication review. Money, can she afford them? Does she know how to take them, or did she take 2 today? Or can't read the dosage, or can't cut them in half. Functional ability, can she open the lids on the pill bottles, or can she even get to the store to pick up her pills? So a lot of different team members would be very useful in fixing that problem. And then there's throw rugs. My mother-in-law has throw rugs all over and just had her cataracts done, and her glasses still aren't right, and she's just an accident waiting to happen, and it's hard to fix this problem with some people. OT, PT, home eval, safety eval would be very helpful. And all of a sudden, your outcome with intervention would be maybe not a person who doesn't fall, but a person who is less likely to fall. Okay? So aiming at the factors is what you need to do here with the team. Okay, so just to summarize a little bit, benefits of interdisciplinary team involvement. Combined wisdom and expertise of the disciplines. Just think if you had to go to school to be your basic profession, and then you want to add the knowledge of social work. So you go back to school, and then you go back to school. You're never going to do that. Nobody's ever going to know everything that each discipline learns in school. They bring all that knowledge that they got in school, as well as their wealth of experience. At any one time on an interdisciplinary team, you could have the new people who come on the team with the new knowledge from school. They know the best and they know the latest, and that's very, very valuable. You have the old people on the team who have the experience with the patient population, have figured out what works and what the resources are. Everybody's got something to add. Coordinated care. The physician might take your congestive heart failure and order some Lasix and get her dried out, and then she's ready to be sent home. But if nobody's told the social worker, and she came from the nursing home where they need some time to get her back in, and then she came up with C. diff and nobody told the social worker, and the nursing home doesn't have any isolation beds, then you've got a ball of wax. When you have a team approach, your care can be much more coordinated and much more cost effective. Pooling of information is very, very important, and having a clear vision of where this patient's going and what the plan is for this patient. So, in interdisciplinary teamwork, the team is more and greater than the sum of the parts. Functional, now this is a key word. Diana's going to talk about not functional. That functional, adult, professional, interdisciplinary teams can have great outcomes. You really can. and elderly patients with their complex situations can definitely benefit from the care of an interdisciplinary team. Here we're trying to do teams, and you can tell the difference on the units, I think, that have a team approach and those that have a non-team approach that are starting to struggle with this. And there are definitely differences that the layperson can see in the care. Okay, I'm going to turn it over to Diana.
I have a lot of material to present today, so we're going to do this we're going to start now, we're going to take a little break, and then we're going to come back and talk about a whole lot more material. I'm going to start out today by talking about some of the obstacles or challenges that we face in interdisciplinary teamwork in geriatric care. What I'd like for you to do, particularly since there are people who are listening to this lecture whom I don't know, whom I've not related to before, I'd like for you to think about this part of our presentation today in terms of your own clinical experience, in terms of your own setting. And while I'm talking, while I may not elicit a verbal response, I'd love for you to feel free to take some notes about your own setting, how this might apply. And right this minute, I'd like for you to kind of focus for yourselves on some of the challenges that you can identify in your own environment, in your own setting, challenges to teamwork. The material that I'm going to review today came from several sources, but on the slide are three of the main sources that I've used. I've provided for you the McAllen article, and I particularly am fond of that because it's a survey article, and it'll lead you, if you're interested in learning more, it'll lead you to a lot of other studies. I have cited some specific studies as I go through my talk, mainly when I've quoted somebody, but I also draw your attention to the interdisciplinary curriculum on the third citation there. I particularly drew from two modules, the module on teamwork and the module on communications. I don't see Tony in the room at the moment, but Tony assures me that on our website, our ETGEC website, if you cannot access both of those modules today, you will be able to in the near future. Okay. The literature on interdisciplinary practice repeatedly identifies a couple of problems, and they're problems that we're all familiar with. They're problems of communication and problems of role definition. And typically those are the most significant factors that underpin successful teamwork. I'm going to talk later about roles. I'm also going to include lots of material on communication as I go through this presentation. I would also say in the area of challenges or obstacles that each of our disciplines comes with its own culture and its own philosophy toward geriatric patient care. And because we each in our own disciplines have our own philosophy, our own culture, we can have misunderstandings or lack of sympathy with each other sometimes. The culture, I think, is most vividly described when we talk about specific language or jargon. And I think probably most of us are aware of the issue of jargon that can lead to miscommunication. I'm going to give you an example of a miscommunication issue that occurred on the ACE unit about a week ago. Rebecca Galloway, who's one of the physical therapists, was sitting at one of the modules, and I was sitting across from her, and we were both working on independent projects. And a person came up to the table This was a person, I think she might have been a nurse. She was a member of what we on ACE unit call a multidisciplinary team, not on a Geri team, but another team. And this person asked if we were involved in the care of a particular patient, and we were. And she then tried to provide us with new information, and she said to Rebecca and to me, we're going to keep this patient as a 23-hour observation, but we can switch the patient to a full admit. What we really need from you is placement. So you all in the room can kind of think about how you would have interpreted that. Now, I interpreted this as meaning that the team wanted the patient's discharge plan to be go to a facility. Ramona's nodding her head, Lisa is. That's how we would look at this. We would think that what she was communicating was this patient needs to go to a skilled nursing facility. Actually, maybe she meant a long-term care facility, but that's kind of what I was thinking. Rebecca said she threw into the mix maybe assisted living, but a facility. And then she went on and she said to Rebecca, the physical therapist, but we need your evaluation. So Rebecca's telling me that what she was thinking at that time was, well, that's strange because usually you don't make the recommendation until after the evaluation. So now she's kind of confused. If they've already decided placement but they want the evaluation, I'm thinking they're thinking 23-hour observation. I can't make a placement in 20, Lisa or Ramona maybe or Donna, maybe y'all could, but I'm not that quick usually. So I didn't think I could do the placement in 20. So this is all taking place, of course, in a shorter period of time than it takes me to tell the story. But at any rate, finally, with Rebecca and I making all kinds of eye contact, rolling our eyes, not sure we understand, checking each other out, finally we decided that we better go for the question, which was what? What do you mean by placement? And the person replied, oh, just some place for them to go when they leave the hospital, which really just is the same thing as a discharge disposition. So this is very simple, right? I mean, it's just one word, but it's an example that really brought it home to me how our use of language, even very basic use of language, can get us into trouble. So misunderstandings can result, particularly in an interdisciplinary setting where team members do not always possess a basic understanding of each other's knowledge, skills, and values. Let's have another one. And I liked this quotation. Most physicians equate, this was in somebody's study that I've quoted there, Clark. Most physicians equate quality of life with mental status or freedom from mental impairment, while nurses equated in this study quality of life to physical strength, seeing, hearing, or having someone who cares. So we can all be in the room together, the doctors and the nurses, and we can all be talking about quality of life, but we may be having different perceptions, different ideas about what quality of life may mean. Okay. Some of the problems, Cheryl said I was going to talk about the problems or the challenges or obstacles, sort of not a good team, not a great team, but the problems that can occur. I've just tried to list a few for us here. These are some of the problems that can occur in team communicating. And I have a funny feeling that pretty much everyone in this room has participated on some kind of team. And so these may not be strange ideas to you. But if you are a member of a team and you begin to notice within the team meeting that there's tension, that's a problem. that's going to be a problem. And for many of you here, you've got keen abilities to sense emotion. So if you begin to have that sense of discomfort, pay attention to that feeling that you've got. Why is tension a problem, or why can it be a problem in a team? I think that it can be a problem because if you've got tension spreading, which it may well do, then you may have folks who cannot focus on patient outcome, which is going to be one of our strategies for coping with problems. Another problem to watch for in team communicating would be opinions expressed as facts. You know, within the team setting, we want to be very careful as team members to present what we know, not necessarily just kind of what we feel or what we put together, okay? Because after all, as human beings, we all come to the team with our own personality, our own personal set of values and standards, and within a team caring for patients in a hospital environment, we're interested in just the facts, ma'am, primarily the facts. I also get concerned within a team when somebody presents a statement, makes a statement, and there's just dead silence. You know, and I have to admit that there have been occasions when I've been that person who's made that comment and then it's just total silence. And you know, I don't know how it makes you feel if this ever happens to you, but it's a really uncomfortable feeling, and it is a problem for the team because now I don't know whether you're silent because you disagreed or whether you're silent because you don't like my comments in general or you discount them, or whether you're silent because you just assume we all know that already. I don't know what that means, okay? So we need to be cautious when we have a team operating where there are statements made with no acknowledgement. A sort of corollary of that is negating or discounting a member's opinion. If you have a person on your team who repeatedly has input that the team finds to be not so useful, you may find that in time the team will begin to negate that person's input or just discount it. This is again a problem because after all we may be, by doing that, missing out on input from an entire field of knowledge, skills, values, expertise. Other problems that can occur, and I do want to assure you that in our second part today, I'm not going to focus just on challenges and problems, okay? We're going to talk about strategies, but still we're on problems. Sometimes you will find on a team that a person, particularly somebody who is negated or discounted, may simply withdraw. Okay? And this again is a sign that you've got a problem on your team. And you do want a team where people take responsibility as team members to share in on the ideas and the discussion. If you find within your team that you're going over the same material repeatedly, that's a problem. Maybe you have too much time. It certainly isn't cost effective, right? And sometimes when you have repetition of points, it is a sign that the discussion's in a rut. You're just stuck. And so, again, for strategies we'll talk later, maybe you need some new input, maybe you need to refocus. Frequent digressions, this is a problem that I sometimes bring to a group because I will be reminded of 47 other incidents of something, and after all, that will sidetrack the team. We have to stay on focus, on target. And the last one that I mentioned in this section is sidebar conversations, and those of us who participate in teams know how distracting it can be when 2 or 3 people are in the back of the room carrying on a conversation and not part of the discussion focus. Traditionally, we all know that we have communicated in a healthcare setting by writing in a chart. And I do want to point out in this challenges section or problem section, some of the problems. I'm just going to hit the surface because most of us are aware of these problems. First of all, we know that not everybody reads our notes. And when I was a new social worker, I was just crushed by this because I really thought that everybody wanted to know what I had to say. And of course, they just don't. So that's a part of maturing, I think, is understanding that. So not everybody is reading that note that I've written or that maybe you've written. Not everybody, again, this is an old cliche, but we all know it, not everybody writes legibly. So you think you're communicating and you're just working away on this note and not a soul can read what you've written. We know this happens, and I know that there are efforts in a lot of locations to resolve this with computer entry charting. The social work note on the ACE unit is placed not within the progress notes, but in the consultant section of the chart. Now, I know that, many of you know that, but many people don't know that. It may be that you want to know, and by the way, the OT and PT note is also there in the consultant section. So if you don't happen to know that particular fact, it might be a problem for you to try to find those notes. And maybe you don't have enough time to go looking. Sometimes we all know there's more than one chart. And for people who practice in community settings, perhaps you have some files that go with you. Perhaps you have a chart back in your home base. For people who work with home health care, maybe there's another chart in the private doc's office, in the specialist's office. So on the ACE unit, there could be a main chart, there could be a nursing chart. At one time, there was, in addition, a respiratory chart. So that can create a problem. And then the last of this list for traditional communication is, unfortunately, not all of us are wonderful at expressing ourselves in writing. I mean, some of us struggle to express ourselves verbally. Some of us are better at one or the other. Some of us are limited in all areas. Whatever, not all of us write what we mean. And even those of us with great skills maybe don't write what we mean all the time. So these are some of the difficulties with traditional communication. Most of you in the room write in charts, right? So you're pretty aware of this. Anytime that we talk about teams in geriatrics, we have to recognize the GITT, the Geriatric Interdisciplinary Teamwork Training. The Hartford Foundation sponsored teamwork training in 8 facilities. I think Baylor was one of them. There are 7 others around the United States. And the idea was we need to strengthen the professional person's skills in teamwork. Now, you realize those are different from your skills as a nurse or your skills as a social worker, where I maybe need to learn to interview and learn to counsel and learn to assess. That may be different from the skills needed to do teamwork. So this was an effort to train nurses, social workers, and physicians in teamwork skills. And in 1995, some folks came along and did an evaluation of that training program. And they found that attitudinal and cultural traditions of the different healthcare professions, which they, by the way, called disciplinary splits, were important obstacles to optimal interdisciplinary team training. Now, to go a little further on that, nursing and social work have long traditions of collaborating. OT and PT, frequently those professions have been complementary. All have a tradition of communicating across disciplines. Who am I leaving out? Yep, I sure am. Pharmacies, Cruchet's out of the room now, even pharmacy has a history of collaborating maybe in some distinct ways with nursing and with physicians. Conversely, in medicine, collaboration is not usually something that we expect that physicians are taught. And in fact, this gets back to the culture. In fact, when we train physicians, we have a value of independence. So one of the findings they had when they did the evaluation of the GET was that medicine was the least enthusiastic in terms of being trained. And they had the study here from GET is really kind of interesting because they also talk about, you know, some of the problems that they had with residents and social work students. They would pair them up together and do some training, and the residents would perceive themselves as being higher on the food chain and would not want to be paired with someone that they viewed low. So status and hierarchy remain with us as issues. Also, we're just, as I said earlier, we're just not taught teamwork skills. And I would just rhetorically ask the questions, where do we learn to communicate? Where do we learn the skills that we need to be effective team members? Where do we learn about issues like role differentiation, role blurring, conflict resolution? Where do we learn interdisciplinary practice? Do we learn it in our separate disciplinary education system? Values. Values certainly affect teamwork, and there are those who talk about something called a worldview. And philosophically that gets pretty complicated, but there are those who feel that you need to have people on your team who have a common worldview, a common way of sort of framing the world or looking at life. In the McAllen article, she cites this study which reported that nurses, and I've thought a lot about this particular finding, nurses valued individualism, caring, autonomy, holism, and patient well-being. And they contrasted this to the social workers who were valuing liberty, collectivity. Donna, it takes a village, right? Equality and social justice. Now, I've thought about this, and frankly, maybe some of you at break can tell me of an example. I've tried to think about how that particular difference might affect us in our teamwork. I don't have a wonderful, easy example, but I think that the fact that some of us have a value for physicality, as I mentioned earlier on quality of life, while others may value more cerebral activity. I mean, these are just kinds of differences among us that can affect how we communicate and how we work together. Unresolved conflict. I want to differentiate this from difference of opinion. Conflict here in this regard does not mean a difference of opinion. I'm really thinking of war here. This is not good for a team. And it certainly affects the team if you have conflict. If you have people on the team who are warring, if you have people on the team who have particular needs to win, and if they win, somebody else has to lose. If life is viewed as a, sort of win-lose situation, you may have some real problems on your team. And it will affect not just the outcome, but of course the process. And I can just say experientially, it can make people regret having to be a part of a team. This can be very unsettling. And it can be unsettling if 2 members are at war and the rest are not. It doesn't have to be everybody in conflict.